We presented the latest data from the AML18 study, which was a study that ran for 8 years in the UK and Denmark, closed at the end of 2022. And it was the latest of a line of studies looking at intensive treatment approaches for patients over the age of 60 with newly diagnosed AML. So the data we presented yesterday was the results of what we call AML version 2, which was a randomized assessment of comparing what was the best standard care option coming out of the first part of the study, which was DA with fractionated myeloid, with the liposomal formulation CPX-351 for patients newly diagnosed, not known to have adverse risk cytogenetics. So we randomized 439 patients over just over 3 years. It was quite impacted by the COVID pandemic. So we started recruiting about 25 patients per month, but it fell away and we had to adjust the trial somewhat and change the primary endpoint from overall survival to event-free survival. So the data we presented, 439 patients who were randomized 2-to-1 CPX versus DA myeloid, median age of 68. About a third of them were over 70, so it was an older population. And because we were looking at non-adverse risk cytogenetics, very few of these patients had secondary AML. About 7 or 8% had adverse risk cytogenetics and had to be treated before the cytogenetics result was through. And I think what is quite topical is 60% of these patients roughly had MDS-related genetic changes on the molecular genotyping. So I guess the headline results were that we didn't really confirm superiority of CPX-351. Really, DA with fractionated myeloid emerged as the preferential treatment for this group of patients. So we saw deeper remissions with DA myeloid, particularly after the first course of chemotherapy, where we had a greater number of patients who achieved MRD negativity right across the genotypes, but including in this subgroup of MDS-related genetic changes. We also found that both the original endpoint and the subsequent primary endpoint of event-free survival and overall survival were both significantly superior in the DA with fractionated myeloid group. I mean, there were a couple of other things we looked at. About 40% of these patients went to transplant and had an allograft, and the long-term survival in both groups of patients was equal in patients who got to allograft. And there was also a second randomization where patients in the CPX arm who hadn't responded optimally following the first cycle of chemotherapy could be randomized to have an intensification of the dose for cycle 2, but we didn't find that made any difference to the long-term outcomes. Yeah, so I think that the conclusions were that for this group of patients who are not known to have adverse risk cytogenetics, it seems that our existing standard of care preferential option from the first part of AML18, which is DA with 2 fractionated doses of myeloid, remains the superior option for that subgroup of patients.